Hey, we're live now. And we have another face with us tonight. I'm so excited to welcome Sheena Jeffers, who's joining us. And she wears a lot of hats, but one of them is doula. I don't do this often, but is it okay with you guys if I read your bio? Because there's just so many different things that you're bringing into this conversation. I want to kind of put them out there first. So she's a certified healing life coach and a ToLabor-trained birth doula. After her graduate studies, she traveled the world on a sailboat, learning further about healing, community care, and seafaring. Sheena focuses her energy on humanitarian work. She created a dance camp for children with incarcerated parents, a community storytelling project that turns stories of resilience into performance and fine art. She's now a volunteer birth doula for the Afghani refugees living in Virginia. And she lives in Richmond with her husband and son, where she's putting the final touches on her memoir.
Yes. Hi, I'm so glad to be here. So glad to be here.
Thanks, Sheena, for joining us.
Yes, thank you for having me.
So I don't know if everyone knows what a doula is. And so I thought maybe you could each define your role as it relates to delivering babies.
Sure. Well, would you like to go first?
No, go ahead.
Okay. Well, so a doula is a professional support partner that you have asked to be in the room with you during your laboring experience. So our training includes, how do we support the birthing body as well as the partner of the birthing body. So that can look like many different things depending on what kind of environment you would like to birth in. But it involves a lot of education, and then it also involves presence. So we are there with them as they go through their pregnancy, and that is just educating them on what a physiological birth looks like. And also going over what a birth plan would look like with them. So ideally, how would you like to feel during this moment? Ideally, what would you like to happen? I know that birth changes based on a million different factors. One of the factors being that the people at the birth are not just the parents. It's also the little baby. And so the baby's changing heart rate or, how they're handling contractions, all of these things can also change a plan. And we know as humans that when your plan gets changed, that can be stressful. And so a birth doula is also there to be that partner of support when plans change. We're there to help give information. We're there to help be like, maybe you want to ask this question. We're there to advocate for the parents, for the baby. We're also there to start conversations, right? Because sometimes the doctors are very busy and they might go ahead and start putting into action something, and maybe they don't have time to communicate what's going on. And so sometimes we're there to just, say, hey, do you mind telling us, mind explaining to her what you're about to do? Or we're there to just keep the communication flowing so that basically everybody feels safe, secure, and soothed throughout that process of bringing a baby into the world.
So, Dr. Ajo-Karens, what about you?
Well, I'm a trained OBGYN. I think most of our listeners know that just based off of our conversations here, and maybe more familiar with the obstetrical side of the field. And so in that portion, as a OBGYN, total, I'm a women's health physician. That's what I focus on, women's health. That's throughout the lifespan, from youth and to postmenopausal age. But in obstetrics, I focus on women who are pregnant. If you even want to start before pregnancy, women who are considering conception, and then women who are pregnant, and then in the postpartum phase also. So as an obstetrician, my main job is preparing a woman for delivery, helping her keep a healthy pregnancy, and then also delivering the baby, and in the postpartum phase, helping her as she transitions out of pregnancy to do that in a healthy way. Um, Depending on, I guess for most women, the relationship that they have with their OB, or the practice really that OB is in, I think that dictates the level of intimacy that you would have in a relationship with your obstetrician, meaning if that obstetrician is the one that you see every week or every visit, and then also if that obstetrician is the one that delivers you. For me, in my past practice, I delivered my own patients, and I also delivered patients that were those of my partners. And so I stress delivery as opposed to vaginal, because in delivery or normal delivery, I hear that term often because in my mind, a delivery is a delivery. And so we focus on doing that in a healthy way for the mom, who is my patient, and also the baby, who is also a patient until the baby's born. Um, and so as an OBGYN, that requires training to first become a physician in school, and then specialize in obstetrics and gynecology, which that's in residency.
Mm-hmm. And
And
so,
I think, the biggest part of our role is not only in the performance, but also the education, and really should be in the support too. I often say that anyone can deliver a baby because that's true, because the field of obstetrics is not as old as women had babies. And so in the past, even in this country, most babies were delivered by midwives. Midwifery is a big part of obstetrics. And if you're a good obstetrician, you also learn from midwives, or I feel you've learned from midwives too. But we have the ability to go past just the normal delivery and work in the more complicated, more complex situations, and also have surgical interventions if necessary.
so, so I want to ask what drew you guys both to this field? Because it
Yes.
can be high stress, I would imagine.
Yes, and I love that Dr. Ojo Cairns just mentioned the fact that midwifery was that midwifery is a powerful arm of delivering babies. That's what brought me to birth work, is that I had an experience with a lovely midwife who she has been doing home births for 50 plus years. And I got access to her name because you have to know somebody to get in touch with her. And I actually decided to go with her, and she is a certified nurse midwife, and she only does home births, and had just a beautiful experience with her. And it was beyond the fact that I felt I completely cared for in, my physical health and my pregnancy. I also felt completely, I was without fear through the whole process, without fear. And even, when I was 8 centimeters and it was discovered that I had a frank breech baby, and, here I was home, and we had to transfer to hospital, I still felt that I had a home birth experience, even though, we did transfer to hospital and we were joined with a doctor. It was still, she kept it as such a safe experience. And I thought to myself, I'm like, look at the power between, midwives, doctors, and doulas. And like, look at what can be done with, all of these minds and hearts, and when they're in the same space, and the caring level is so intense. You know, though I had a frank breech baby, I was still able to deliver vaginally. And, you know, everything was safe and everything was calm and was great. And I left that experience feeling so empowered. And that's what brought me to birth work. And after that, I was like, I want to go be certified. I want to be in birth work because I want women to walk away from their birth experience and think like, wow, like look what I just did. And less like, whoa, what did I just go through? And I think the key to that is that education and that care and just that taking away the fear.
Mm-hmm.
I entered the field for empowerment. My goal, starting and always, has been empowering through education and helping my patients to gather a better understanding of their bodies and the situation that they're in, and to make informed decisions. And I think the biggest part, from what I'm hearing from you, Sheena, of being able to have that lack of fear, is because that you had presence of trust. And I think that that's the biggest key to any type of relationship. You know, oftentimes obstetricians, midwives, doulas, and can have complicated relationships, and that's just real. That's just fact, because we're all in an instance, especially if all three branches are present in a birth, or have been present in the care of of a woman throughout her pregnancy. We all have intentions of working, or should have intentions of working for that woman's betterment, to her benefit. And sometimes we can cross one another. And I think the biggest thing is understanding that the goal is the same, which is for the baby to be born healthy, and for the woman to have the experience that she hopes to have. Or at least, let me say this, to have the experience that is positive and keeps her healthy. But that trust factor has to be there. And I think that trust factor not only has to be there with the patient, but has to be there amongst caregivers, whether it is a labor attendant, if that is a midwife and a doula, because certainly, if I'm correct, doulas you don't have to work with just a patient that's trying to deliver with an obstetrician. You can also work with a patient that's delivering with a midwife. And so that trust should be amongst all the attendants. And, you know, you have to have that same trust of self. And so the only reason one can garner or allow those that they care for to trust them is that they actually trust themselves with their ability to give care. And so what does that mean? That you have to be proficient, that you have to be cognizant, that you have to be skilled at what you do. And so we all come in at different points in care, and with different levels of skill and different abilities to offer, right? A frank breech vaginal delivery, that's not your norm. That's not your norm for most midwives, because that is not the norm for in America right now for a term delivery, period. Now, let's say, I don't know, 50, 60 years ago, did you see that happen more often than not at a delivery that was attended only by a midwife? Probably so, because you would have more breech vaginal deliveries, but you don't have that now as much, especially for women who are giving birth the first time. So that would take a next level of skill if you know, the first attendant's not able to do that. And I say attendant because that could be also with an obstetrician that doesn't do breech deliveries. You know, you want somebody else skilled. And so it is very important that that first person has the ability to say what my limit is, and when I have reached my limit, and when I need to move on and have somebody with higher level help me out. You know, the problem that we have in this country is that relationship. And I think if that relationship was a bit better, that you would have an easier transition from delivery locations, meaning home deliveries that go awry, or home deliveries that have complications getting into the hospital, But I think that also comes with being okay with kind of letting go of your authority in
Mhm.
some sense. And that can be challenging for obstetricians, midwives, and doulas from
Yeah.
my experience. I had an experience this weekend, not to belabor the point, but I had an experience this weekend where I, I I was told by many people that I'm patient, and I took that and thought, "Ooh, I don't know about that." But what
Your middle name means
my
patience.
middle name,
CD means patience.
but I think what I am is tolerant, and I've had, and so maybe in some that can be taken as patience, because I've had wonderful relationships with midwives and wonderful relationships with doulas, but I'm also open to say, you know what, I've tried my hand. Can you help me? And I
Mhm.
think on all ends, that really has to happen for a relationship to be, one that's positive and one that generates something worthy.
Yeah, it's true that definitely makes a difference. And I did trust my midwife to make a call, and she could have told me sign over the deed to your house right now, and I would have done it right at that moment in time, because I just trusted her endlessly. And she works with a doctor at the hospital. She called his cell phone and said, I have a first time mom, and I have confirmed the baby is frank breech, and can we come in? And I got after the next contraction, feet on the floor, we're going to the car. And it was a 8-minute drive to the hospital, and then he was in the room with us. And he, between the two of them, they were able to do that delivery. And I think you are right that they both have been practicing in this area for 50, 60 years. And so they both felt capable of doing that. And so that trust aspect is really key. And
Yeah.
when to pass, the expertise around the room, and also when to say, like, I need to go focus on this. Like, let's tag in the doula, or let's tag in the midwife, or let's tag in the doctor. Like, it's care is so communal, and it's really nice to see in birth work when it is that way.
Mm-hmm. I had an experience of having a midwife, and I had the option of OBGYN or midwife, but I was told that the OBGYNs that would see through my pregnancy would be on a rotating basis. And so I chose midwife primarily because I wanted continuity of care up to the delivery. And then when it came down to it, I had a complication and baby was stuck in the birth canal. And so midwife and OBGYN on call were arguing over me about, midwife thought I could do it. I could keep pushing. OB was uncomfortable, said, let's go. And so both were advocating. And it didn't feel to me like it's not just a simple matter of ego. This wasn't just them trying to win. This was them believing that they had my trust and best interest, but two people believe they had my trust and best interest. So in the moment, I had a nurse who was with me, who was coaching me through while they were making this decision about whether I go or not. And coming out of that situation, my husband's perspective was, how wonderful. Like, the argument didn't bother him, because he thought, you have these two people who are advocating for your care, and what you're going to get out of that is the best possible care. And I was like, I'm glad that the nurse was there to keep me breathing and focused while in this tremendously precarious moment. And so my experience plus TV and what Mindy Kaling would have us believe is that there's a great deal of friction. And I wanted to ask, like, has that been you guys' experience? Is there a lot of friction between these fields, or is that not always the case and maybe sensationalized?
Oh, that's a great question.
I would say it's both. I mean, you have to be honest with with the situation. Like I was saying before, I think it's dependent on individuals. For me, things don't rock me that much, or that, so I try to find the middle ground. But yeah, there can be friction because it's high stakes. And is it sensationalized? I think it can, in some ways, maybe. But again, a life is on the line, right? And some big calls are on the line, whether you keep going vaginally and potentially have some complications vaginally, or you have a C-section and maybe have complications from doing it too late or whatever, you know. We're trained on the think of the worst scenario and be prepared to handle that end, because we always have to remember this. Being pregnant is probably one of the most dangerous things a woman can do. We often talk about the beauty of pregnancy and the beauty of labor and the beauty of delivery. But around the world, childbirth kills women all the time. The aftermaths of childbirth kills women all the time. And so coming from that end, the surgical end, or coming from the physician's end, we're trained to handle the worst case scenario. And so sometimes we come into a situation with that in mind because we really want to prevent that, you know, because if things go awry and you need to move fast into any type of operating theater, or you need to move fast to do any type of um, assisted delivery, surgical delivery, it's going to be the person that has that ability to do that that's going to be called in. And I think then that's where you have personalities that can be different. And so maybe if the conversation started differently in training, or the conversation started differently as a whole, as what the relationship should be like, the environment was different, like it is in Europe with midwives, doulas, and obstetricians, maybe that relationship would be different here in the US as a whole. But I wouldn't say that for everyone there's friction, but I think globally it can be complicated. And I think globally they're known to be complicated relationships. And again, I think a lot of it also comes with understanding everyone's role and everyone understanding their role too. You know,
Yes.
if I have a patient who has a doula that they have had a relationship with for months, the entire delivery, I can't dismiss her. You know, that's not right. They have a relationship and she trusts that person. And so I have to integrate her in the discussion as much as the patient wants her to be. I can't just discount her. Same thing if she had a midwife and it's transitioning her care. Good night, sweetheart. And it's transitioning her care over. So I think, that has to be mindful. You have to be mindful of that, but that's also, the individual.
And that's an excellent answer. And I want to just follow up with that. I mean, you said everything beautifully, but my experiences of being on labor and delivery floors have been, I've always felt that the doctors have always integrated me into the conversation, but I also know my scope of practice, and I am very, very quick to say, this is where you need to listen to her. Because I think what's really important is understanding kind of the pathway of what birth looks like, right? So once labor has started, you're kind of on this pathway. And now the pathway, it can be easygoing until, vaginal delivery and the mom is like, this is perfect. But it can also take an exit that you didn't expect. And then now, every decision that you make on that exit is going to take you somewhere else, right? And so there are options that can, once you are on this exit, there are options that could bring you back to a vaginal delivery, or there are options that time starts speeding up a little bit and now we need to make, a very quick decision. So I think that as a doula, kind of my role is to help them understand that pathway before they're even in labor. So that once they're in labor and they are on that road, and now they know okay, they're getting given the options, right? Now we're talking induction, or now we're talking, we need to do continuous monitoring, or now we're talking like, we're going to let you push for 1 more hour. We can try the vacuum, or we can do a C-section, right? Like once you start getting into places like that, I feel like my role is really done before they get there. My role is to help them understand their options so that when they get there, they can be like, okay, yeah, no, I know how to confidently, walk this terrain. And, one of the things that we teach them before they even have their first contraction is this idea of brain, where it's like, we want them to know the benefits, the risks, the alternatives to everything they're going to be presented. We want them to know what their gut says, so that intuition. And then the last and final letter in is, okay, well, what if I do nothing? Is that question of, what if I do nothing, right? Do I have time to discuss this right now, or is it an emergency? Right. That way, like, they are advocating for themselves as they go throughout the process, and advocating for their baby as they go throughout the process. So that at the end of the pathway, they don't look back on it and feel like, whoa, I got, steamrolled by this experience. And I feel like I got left back at contraction 1. But I think, like, when you have doulas that are working with midwives and doctors, when you have that process and you're on that pathway together, and everything feels informed, and everything feels consensual, and everything feels, like, okay, yeah, I know the benefits and the risks of this, and I know what I'm choosing, and I can, move forward in confidence. I think that's where, if everything doesn't go as planned, and you have a mom that ends up having to go into a C-section, they're going into the C-section knowing why. Because they've now, like, they know, they've been told why they arrived there, and they know with confidence, why they're there. And that way, like, they're not blaming themselves. They don't feel like they failed, and they're going in there to meet their baby, which is a whole different feeling of, like, being rushed into an emergency C-section because you failed.
Well, yeah, and I echo that, because a C-section after attempt for vaginal delivery is not failure.
Right.
It's another route for delivery.
Yes.
And so I think framing the understanding of just the act of delivering is really needed in this country. And that's and that's on all levels. And I honestly think that's the responsibility of those who see the patient before they come into the hospital, or have a delivery attempt at home, or whatever. That's on those that are caring for them in their while they're having their visits. Because that's part of the education. And then again, we come back to that understanding of trust. And if there's one thing that I wish women who are hoping to have midwifery deliveries, or want to have doulas as part of their team, understand, is that there should not be pitting against different attendants, or different individuals that are coming in to help, because ultimately everyone's coming in to help. But there is all the reason to do what you said, Sheena, which is advocate for yourself. And that's to everyone, There should not be any type of adversarial relationships, or interactions. I'm not your adversary. I'm here to care for you. I've had many experiences with patients who have been brought to the hospital because they were unable to deliver at home. And immediately I've oftentimes felt negative energy in the room, because I'm the obstetrician. But that's unfortunate, because it does have an impact on care. And so if it's discussed at the beginning of the relationship, whether you're an obstetrician and you have a patient who comes and sees you and says, hey, I'm thinking about having a midwife too. Okay, let's have that conversation. There should not be any negative words passed. Same thing for a midwife. I have a patient, or sorry, I'm thinking about, transitioning to an obstetrician, or having an obstetrician as part of my team. There should be acceptance of that. If you're bringing the doula on, hey, I can't decide whether I have a midwife or an obstetrician. It should be whatever you feel the most comfortable, but understanding that labor is in charge, not you, right? And so I think that's where a positive relationship would start.
That's perfect. I was just going to ask what's one thing, because we could probably go on and on. I could go deeper about the question of where this came from and this judgment around how we have a baby and like how that impacts our womanhood, and like when then bringing that into the room. But we're getting close to the end. So I was going to ask, what's one thing that you would say to women who are, or people who are expecting? Is there one big thing? And I heard from you, Dr. OBGYNs, to advocate for yourself and to be aware that you're building a team of people who are going to help you usher in your child. Please add on if I missed something from that, but just a thing that you would have ring in the ears of people who are anticipating bringing a baby in.
Well, I would also say, just know who you're asking to deliver you. That's on all ends, And so if you are looking for a doula, I do encourage that. You want someone that is experienced and is giving you valid advice. And so, look around for someone that has experience, that has had a number of deliveries under their belt, that's associated with a team. I think that's great. Look for a midwife that has experience, that has had multiple deliveries, not just attended deliveries in home or in the hospital. Look for a midwife that has some type of backup or backup plan. That's important. And then you look for an obstetrician that listens. Yeah, I'll be the first person to say that oftentimes, doctors may get in their own way and not listen, but that's not right. You definitely can have the same positive, trusting, fear-free experience with anyone. And so that includes obstetricians. And so I would say that would be my last piece of advice.
Yeah, I think that is great advice. And it does make all of the difference in how you feel comfortable and how you feel safe and how all of it makes all the difference. My one thing of advice would definitely be, I'm just going to tag on to that. After you've created your care team, don't let fear keep you from asking questions. So if there's something you don't know, don't be afraid to say, I don't know how to ask this, but I'm going to try and describe something and see if, you know the question. Because a lot of things that I hear that moms are like, my appointment was just kind of rushed. They checked my blood pressure and they checked my weight and they asked me if I had any questions. And I think I have questions, but I didn't know what to ask. Right. And I hear that all of the time. And I think it's because, a lot of times, people assume that there has been a generational knowledge passed down of pregnancy and birth. And I don't think we have that anymore. I don't think we have it the way we had it previously. So now we have generations of women coming in that are like, I've seen movies. And that's what I think birth is like.
The water breaks, and then you have a hilarious hijinks ride to the hospital.
Yeah. And they also don't feel like they have the time, or they're afraid to take up the time of their doctors. And so they don't know necessarily what to ask or how to ask it. So then they get to that first contraction and now they're scared because they didn't ask any questions. They didn't know what to ask. They didn't have mothers talk to them about their births. They didn't have grandmothers talk to them or aunts talk to them. So I think that it's a component that we no longer have as much of. And so because of that, I think it's really important to seek out that care team and then, go into that care team just with pure honesty and say, I don't know what to ask. I don't know what to feel. I don't know what to expect. I don't know what to tell my partner to do. I don't know how to set my house up. There are things that that used to be taken care of by just the community and by the family. And, now I think there's less of that.
Yeah.
And I think that shows up, once they're in labor.
And, it's unfortunate because the hospital stay time is also less.
Yes.
And if you're having a home birth, also, that same education can be lost if your midwife isn't doing regular postpartum visits. And so I always say this, write your questions down before any visit. With my when I was seeing OB patients in the office, I'm going to see you a lot.
Yeah.
So you're going to come here and you're going to figure out what your question is. Your phone is your friend. Put it in the phone. You keep your phone with you. When you come here, we'll go through your phone and we'll talk about it. Everyone is different in how they're able to take time in the visit, but I know we don't have much time, but pregnancy visits are kind of the same because everyone goes through certain points in their trimester. So at 15 weeks, we can have the same discussion at 18 weeks, 20 weeks, and so on and so forth. Maybe your obstetrician doesn't take that time. Maybe your midwife honestly doesn't take that time, but you can take that time, write your questions down so that you can bring them forth and remember what the entire question is. And, there are a lot of wonderful resources online. And so if you don't feel like you're getting the education, the level that you want from your provider during your visits, thebump.com, honestly, I did that when I was pregnant and I was already a practicing OB. And I did it because I wanted to see what my patients would feel. And I was just amazed at the emails I was getting each week, and they were spot on with what you should be feeling and what you should be doing and what you should be thinking of. And so we as a society have to stop only getting our education in the office of our practitioner, whether that's midwife, doula, or doctor. We have to go out and seek education. We are, if you can read, you can educate yourself, and so take that initiative and take that control and educate yourself. There's a lot of information out there. If we can be tweeting and reeling and all those other things, Hannah, that you're teaching me to do, we can be reading. And so I would say that,
don't read the comment sections from other scared, confused pregnant ladies.
Yes.
Well, that's not the right place. Vet your locations because that spun me out.
Yeah. ACOG.org, American College of Obstetricians and Gynecologists, or gynecology, excuse me. Great information for throughout pregnancy, great GYN information. I said I did the bump. I thought that was amazing. I thought it was cool. So there's a lot out there. And so I encourage people to educate themselves.
Yes, that's great advice.
Okay, I'm just going to drop acog.org, right?
You know what? It's .org or .com. Google will correct you.
We're going to put it in the comments. And if you watch this and we're not live any longer and you have questions, please feel free to drop them in the comments. Or if you're watching this on YouTube, other questions that you have, if you like a little bit more, please let us know. You guys, this was such a good conversation. Yeah. Of course, we had to go longer than 20 minutes. Yeah. I don't even know how we're going to cap it now. But thank you both for being here. And thank you so much for the work that you do. I definitely don't want another child, but if I did, it would be with you guys.
Yes. That would be a great time.
I don't know. I'm not that great as a pregnant person. Good night, you guys. Thank you.
Good night, y'all. Thank you.
Good night.